This is the lecture on randomization. As we have seen earlier, a randomized controlled trial is a special case of a prospective cohort study. And in a cohort study, our study population is divided in two groups, one of exposed participants and one of non-exposed participants. Both groups are followed up over time, and after the follow-up time, we compare the number of occurrences or our outcomes between the two groups. The special characteristic of a randomized controlled trial is that the division between exposure and non-exposure is completely due to chance. Randomized controlled trial is all about testing the efficacy of interventions. And interventions can be taking specific drugs, but can also be other things like adhering to a program. A randomized controlled trial can only be done if there is the situation of equipoise, meaning that there is a genuine, not enough evidence to decide whether or not the intervention is effective. If you already have enough evidence for the effectiveness, then it will not be ethical to run a randomized controlled trial. The idea behind a randomized controlled trial is that we assess the counterfactual, the situation where we like to have the answer, what would have happened if this group of persons would have had the intervention? And that situation is never observable. You either get the intervention or you do not get the intervention. If you would have been able to assess the counterfactual, you would have to be traveling back in time to look what would have happened if the participant had the other situation. Randomized controlled trial is a methodology to assess this counterfactual that is actually not observable. Let's look at an example in a study that has as outcome cardiovascular disease, either a heart attack or a stroke. All the participants in the population will have some inherent risk of getting the outcome, whether or not the intervention is taken. The problem is that we do not know on forehand who will get the cardiovascular disease and who will not get the cardiovascular disease. But in the population, there are some people that will, in any circumstance, get a cardiovascular disease. So what we try to achieve is that the underlying risk of cardiovascular disease is similar in the exposed group and the non-exposed group. So let us look at two situations. The first situation is a wrong division. If we have in the green the exposed group and in the blue the non-exposed group, then we can see that in the exposed group there are more people with an inherent risk of cardiovascular disease compared to the non-exposed group. In other words, the baseline risk, the underlying risk of cardiovascular disease in the population is not equally divided over the exposed and non-exposed group. This will be the right division. Here we have been able to divide our study population in two groups and both have the same underlying risk of cardiovascular disease, both in the exposed group and in the unexposed group. So the question is, how can we make sure that when we divide our study population, that we end up with a division like this? So the correct comparison will then be that we have an exposed group with a certain underlying risk for the event. We have an unexposed group with a similar risk of the underlying event. And when we then follow both groups up over time, we can really compare what the eventual risk of cardiovascular disease is at the end of the study time. And here we see that in the exposed group, that risk of cardiovascular disease is lower than the non-exposed group. And the only difference between these groups is the intervention. And why is that? Because we made sure that the division between exposed and non-exposed is completely due to chance. So the only thing that differs between the two groups is the intervention. So the core of randomization is chance, making sure that the division in exposed and non-exposed is completely random. Randomized trials have three critical components. First of all, we must prepare a random sequence. And a sequence is a sequential list of allocations to exposed and non-exposed. And each new participant gets the new allocation from the list. Then that allocation from the list needs to be given to the participant or the investigator, and we call that the allocation of the randomization result. And the third important component is concealment of that randomization. And in the remaining, I will talk about all three of these components. So generating the sequence, the allocation sequence. This used to be done in the past with with a table of random numbers. It was page after page after page with these types of blocks of numbers. And before you started to do anything, you made up some rules. For example, you read the table from left to right, or from the top to the bottom, or from the bottom to the top, whatever, as long as you decide on that a priori. You also decide which number indicates an allocation to the exposed group or an allocation to the non-exposed groups. For example, if you only have two groups, you can say everything below 5 goes to the exposed groups, everything above 5 goes to the non-exposed group. And then if we take the first block in the upper left corner, and we decided a priority that we read from left to right, then the first generated allocation is 6. And a priori, we have decided that is the non-exposed group. The second one is a 3. It goes to the exposed group. Another exposed group because of 2. Another unexposed group because of 7, etc., etc. These random number tables are not used anymore because we have much better tools to generate the sequence of allocation. For example, nowadays there are quite a number of websites where you can just fill in the number of participants, the number of groups, and that website gives you an allocation, a sequence of allocation. The problem with these websites is that it is often not possible to reproduce that sequencing. And being able to reproduce the generation of your sequence is very important if you want to be transparent about your study design. So therefore, it is better to use statistical software where you write a small piece of code that gives you the allocation sequence. And that code is is reproducible and is therefore very transparent. So once we have a list of exposed and non-exposed sequences, we need to make sure that that sequence is given to the participant or the investigator. Again, a rather old-fashioned way of doing it, but still happening if other tools are not available, is the so-called sequential numbered opaque envelope. So these are envelopes which have a number, and those envelopes are sealed, and inside is a little card saying exposed, non-exposed. And the investigator gets a whole box of these sealed envelopes, and when there is a new participant, the investigator takes the next envelope out of the box, opens it, and knows which allocation to give to the patient. Another way of doing it, and I think that is rather creative, is actually a scratch card where the participant scratches away, or the investigator scratches away the little box, which then revealed the exposure or the non-exposure. But nowadays, it is actually a simple algorithm that sends the allocation directly to the phone of the investigator. The third component is blinding or concealment of the allocation. So we should not forget that a lot of persons are involved in a clinical trial, in a randomized clinical trial. Of course, it is the participant or the patient, the physician or the investigator. But we have also people working in the laboratory doing all the laboratory tests. And don't forget that we have somebody who is analyzing the data. So a lot of people are involved. And the fewer people know what allocation the participants get, whether the participant is exposed or non-exposed, the better it is. In the literature, you find certain terminology. You have a single blind study, a double blind study, and you can actually extend it to a triple or a quadruple blind study. And these numbers indicate how many components of your study are blinded, are concealed to the allocation, do not know what the participant is getting. But the word single can actually refer to the participant or the physician, and actually also to the data analysis. And double can refer to any combinations of two components. Therefore, the terms themselves are a bit open for interpretation. And actually, clinical trial guidance nowadays says don't use these terms, but just explain who is blinded to what, who is concealed for the allocation, or to which part of the allocation, which makes it much more transparent and not longer open for interpretation. So there are some special cases of randomization, which I will discuss in the remaining slides. First of all, we have a factorial design. Up to now, we have constantly talked about two groups, an exposed and non-exposed group, and only relating to one single intervention. But it is very well possible that once you have the two groups, after the first randomization, that you randomize those groups again to another intervention, which gives you 4 different groups, 2 with each intervention alone, 1 group with both interventions, and 1 group with nothing, no interventions at all. The advantage is that you can assess the efficacy of 2 interventions at the same time in the same study population. So that might be very attractive when the interventions are expensive or the study population is difficult to come by. The problem is that the analysis of such factorial design is not straightforward, because it is very well possible that the effect of one intervention interacts with the effect of the other intervention. And so it requires quite some analytical skills to analyze a factorial designed randomized controlled trial. We also have stratified randomization. Sometimes we are very worried that a certain factor that is known to be associated with the outcome is not well balanced in the exposed and the non-exposed group. Not well balanced because of the randomization. That happens when there are only a few participants to participate. That are only a few participants randomized, so a very small randomized trial. To avoid then that, for example, by chance, one stratum is not having anybody in the exposed group, you can repeat the randomization within each stratum. So suppose that these stratum reflect socioeconomic status with low economic status, average socioeconomic status, and high economic status. You repeat the randomization within each stratum. So then you are assured that each stratum of the socioeconomic status is having participants in both the exposure group and the non-exposure group. If the randomized control trial is large enough, this is often not needed because randomizing a large number of participants will take away by chance this balance. So separate randomization of the risk factor, proper representation of the risk factor in the final sample. Another reason to do it is that you're really curious what the effect is in each specific stratum. So that is a different or an additional research question. You want to have a stratum-specific measure of effect. And let us talk about cluster randomization. Also here we have groups of people. But in contrast to the stratified randomization where each stratum had both people in the exposed and the non-exposed, in a cluster, everybody is either exposed or everybody is non-exposed. And very typical clusters are health centers, practices of general practitioners, schools, districts. These are really clusters in which randomization can take place. And when we do that, especially when individual randomization is not possible or not logistically feasible. So for example, it is much easier to ask a physician to treat his or her patients according to an exposed intervention, rather than that the physician has to think about which patient to treat how, as an exposed or a non-exposed group. So it is really for improved feasibility of your randomized trial. One of the problems, it reduces statistical power considerably because you have clustered data for which you need to make all kinds of adjustments during the analysis. So you need much more people in your trial, in your randomized trials, when it is cluster randomized, compared to individual randomization. And then we have a step-wedge design. You see that more and more in the literature. It's a very popular design, especially in public health, but it is a very difficult design. It is also based on the clusters, as you can see on the left. So it is a cluster randomization. But now all the clusters, the first measurements of the outcome occurs when all clusters are in the control setting. Nobody has the intervention. Then a few clusters cross over to the intervention. And after that, stay in the intervention. And in the next wave, a few additional clusters cross over to the intervention. So during the time, each cluster will get the intervention. And at the last wave of assessment, every cluster is in the intervention. Why do they do that? Because it allows for a gradual rollout of the intervention. Those STEP-WEDGE design are often large national or maybe international studies where you need a lot of money and manpower to roll out the intervention. And then it is often easier to focus the intervention first in a few clusters and only then move on. So it is really, again, a feasibility issue. The problem is that it requires multiple rounds of measurements every time that clusters move over to a new, to the intervention group. We need again to measure all of the clusters. And one of the problems, it is difficult to analyze. There are still debates going on what the best approach is to analyze STEP-WEDGE designs. Which brings us right away to an RCT. How do we analyze the randomized controlled trial? There are two ways of doing it. The first one is the intention to treat. In an intention to treat, all participants who are randomized are part of the analysis. Whether they or not take the exposure or take the drug or take up the intervention or are adherent, we don't care. Everybody who is randomized is analyzed by the treatment that that person got for the randomization. So by the initial assignment, by the initial allocation. Even if that person switches to stop using the drug or stop using the intervention, still that person is analyzed as having the intervention. This is in contrast to a per protocol analysis, where you actually only include the participants in your analysis who are fully adherent to the intervention. So if it is about taking a drug, those participants have taken the drug every day or every week according to the protocol. If it is about following, for example, a harm reduction program, those participants have been present in each and every group session on harm reduction. And the importance is that for the per protocol analysis, you really look at the theoretical optimal intervention. What is the effect of the intervention if everybody takes the intervention? In an intention to treat, the idea is that it is the more pragmatic effect. What is the effect of the intervention if people are being able to use the intervention? So in conclusion, there is much more to randomized trial than this short video. But the key concept of a randomized trial is chance. Chance of allocation in the exposed and non-exposed group. And because you as an investigator has the power to influence exposure and non-exposure, it is an experimental study. Randomization ensures similar underlying risk for the outcome in the groups. And because the only difference between the two groups is the intervention, it allows for a causal interpretation in the fact. And that is really the preferred approach for an efficacy study. You want to be able to tell that this intervention caused that reduction. And that can only happen if the underlying risk in the groups are equal. So randomization requires a generation of the allocation sequence, the allocation to the participant itself, and concealment as much as possible of the allocation. And that makes it the end of this video.